Thank you, Trish. What we thought we might do, if that's okay with all of you, is we'll take a quick coffee break, because otherwise they'll take all the coffees away. So we'll have a quick coffee break. The quicker you come back, the quicker we can get this session finished and we can get the questioning started. I hope you don't mind, gentlemen who are waiting to question. If we can take some questions after the session ends, we'll have a quick coffee break and come back as quickly as practical. A shaver is mandatory requirement for all ankle arthroscopies, not just fusions. All ankle arthroscopies require a shaver of some sort or a debrider of some sort. You need image intensification so that you can view where your screws are going to go in, and also to assess the position of your ankle fusion. You have a variety of things to destroy the joint, which includes burrs and chondral picks that you can use to get into the subchondral bone. Osteotomes are very useful. You might also want to use a smiley knife. I discovered I had a whole set of brand new smiley knives in my hospital which hadn't been used for 20 years, and I found them extremely useful, and I'll show you that. Over and above all of that, you need patience, which is why I wasn't going to show you a 20-minute video, because it's extremely boring, and you do need patience, and you need to carefully prepare the joint surface. What about positioning? Now, many of us have gone away from using any invasive traction, certainly. There are some of us, including myself, we use gentle traction over a sandbag, no more the traditional use of either using a rigid bollard underneath. Most of us have gone away from doing that. I also use this roll of elastoplast, because when you try and traction a leg, it almost invariably falls into external rotation, which makes your use of the lateral portal quite difficult. So I use this roll of elastoplast and stick it onto the opposite side of the table so that you can gently internally rotate it, and you can change the degree of rotation as and when you want it by asking your theatre attendant to move the plaster. One of the reasons why people have gone away from some severe traction is a potential problem with impingement of the common peroneal nerve. Let's just very quickly look through the anatomy of the front of the ankle, because your portals have got to be carefully positioned. You've got the tibialis anterior, which is a very important landmark for you. You've got the extensor tendons of the lesser toes, and then lateral to it, you've got the peroneus tertius and the lateral branch of the superficial peroneal nerve, and it's in this window that you would require to go through. So if you looked at the surface marking, you'll usually find a soft spot as you follow your way down medial to the tibialis anterior. By palpating the tibia, you'll suddenly dip into the ankle, and that's where you'd need to go. It's often useful practice to try and mark out your landmarks before you traction, so that you are fully aware of the structures at risk. I often try and insufflate some saline so that I know that when I enter the capsule, I get a leak back, so that I know I'm in the ankle joint. Sometimes it's very difficult to actually insufflate anything at all because the ankle is so tight. So you sometimes have to work your way in. You can see that there's a big osteophyte in front, and you simply have to take out all the anterior synovium, try and burr or drill your way through using sharp abraders until you can get a reasonable view of the joint surface. This is very important because sometimes it's a large osteophyte in front of the ankle that prevents you from getting a plantigrade position of the ankle. That's quite important in my view. I also use, and this is the trick that I was telling you about, I cheat sometimes, and I use a fine osteotome which will save time. Instead of burring, causing a lot of heat, sometimes the use of a fine osteotome to chisel away the anterior osteophyte is quite a useful technique, and you can safely deliver that by using an arthroscopic grasper, which you can pull out bits of bone from within the joint. You can sometimes use the burr in reverse, and I find that quite useful, or use the burr in an oscillating fashion, particularly if there is soft bone, or if you don't want to carve into bone, particularly in avascular necrosis, etc. Use the burr in reverse to try and smooth surfaces off. If you're going to work on the talar osteophyte, it's further down, it's almost sort of at the junction of the capsule to the proximal part of the talar neck, and so you might have to take your traction off, dorsiflex the ankle so that you can get that osteophyte into view. Sometimes you have an equinus deformity, which you may have to correct. After you resect your cartilage, you then prepare the bone so that you start entering into the bleeding cancellous bone. And once you've established that bleeding, and this bleeding will occur even in spite of a tourniquet if you do use one. Many of us don't use a tourniquet for this. And then you can safely position your guide wire. And this is the smiley knife. And if you've got situations where you've got one half of the joint which is severely arthritic and the other half which has got lots and lots of cartilage, rather than sort of slowly working your way through, you get big chunks of cartilage that you can take out by using a sharp smiley knife, which is a very safe gadget to use in the ankle in addition. You can use a variety of methods to take out the articular cartilage. You can use a radiocoablator like this to burn away areas which are difficult to access with an osteotome or with a curette. You can also use condyle picks then to try and get, this is a safe method, it doesn't generate heat. You can then start to open up the subchondral bleeding bone surface. And in the bottom left, if you looked at this, that's how it looks, where you start to see areas of bleeding bone. You'll also notice that the surface is like a series of peaks and troughs. And that's one of the reasons why when you get a post-operative X-ray, you see a gap there, because the two surfaces don't exactly match and fit into each other like an open fusion when we've got a completely flat surface. You can then try and work your screws, and as was spoken earlier, you can put them in any direction you want, but you can actually visualize your guide wire going in so that you know that you are in a nice and central position, or you've decided which position you want your screws to be in. I keep them non-weight bearing strictly for 2 weeks in a plaster, partial weight bearing in plaster for another 4 weeks, and different from what Trish has said. I've tended to treat them in a boot for a 6-week period thereafter, not allowing movement, but just allowing weight bearing. And as you can see, when very much like Trish's patients, except that I've got a longer walkway, you can see that the gait is almost completely normalized. Although if you look very carefully, you've got that slight external rotation, and you can see the hypertrophy of movement in the midfoot joints that would allow the patient to use a car pedal, for example. The combination of slightly increased movement in the knee joint and the hypertrophied movement in the midfoot would allow a patient to use car pedals or bicycle pedals. It is important for them to use the facilities of a physiotherapy department in order that they can get some degree of normalization of gait. It does take some practice in order for you to be able to do that. And the radiographs, as Trish showed, you've got X-rays which look as though there is a gap. You can see that you start to worry about it and you say, my goodness, there is a gap there, I haven't got enough compression. But if you get an X-ray a few weeks later, you find that the gap is almost completely closed and you get a column of bone that grows into it. And the reason why you see the gap is, as I mentioned before, you've got a series of peaks and troughs which don't exactly match with each other. Just going through the extended indications, these again are for the experienced arthroscopist. I wouldn't want anybody to take this lightly, but if you are able to get to that skill level, I think it's an extremely useful technique. So if you looked at deformity, there was a paper published by Steve Parsons from the southwest of England, where he showed that even moderate deformity up to 45 degrees could be treated arthroscopically, and it was a revelation to a lot of us who were worried about treating deformity arthroscopically. You can correct angular deformity, and the way you do that is by selectively burring the surface. You often find that whilst the talus excavates into the tibia, leaving a ridge on the tibia, which you can then burr away, the talus in itself is less deformed, so you don't have to take any more effort in trying to correct it to the talar level. The most of your deformity can be corrected by simply selectively burring away one side or the other of the tibial articular surface. With sagittal deformity, it's usually due to a tight tender Achilles or anterior osteophytes. As I mentioned earlier, you can simply cut away the anterior osteophytes to allow you that dorsiflexion. And then if you do a percutaneous tender Achilles lengthening, this would allow you to position the foot in a plantigrade position. As Trish mentioned, I think the position of the foot is so pivotal. You don't even have to look at X-rays. If clinically you're able to position the foot plantigrade and so that the patient is able to stand with the foot flat on the floor. Sometimes this may actually mean that your talus is not perfectly positioned, because it's also relative to the subtalar position. But if you have a composite position of the foot in a plantigrade position, that really is what matters at the end of the operation. You can do a variety of procedures in order to sort of release it. All of these can be done minimally invasively as long as you understand the anatomy. You can do a selective anteromedial medial ligament release. You can do a tip post lengthening or release. Posterior capsular release, sometimes you can do this arthroscopically if you can get it far back. Occasionally you might have to use a posterolateral portal in order to achieve this. You can also joystick this, and this is a technique that I learnt in Germany, where you actually put in a pin into the talus and joystick the talus into position, which is quite a useful technique sometimes. The biological challenges are many in trauma, and this is a patient who had a bad fixation, who went on to get severe MRSA osteomyelitis, and this is what the patient was left with after an Ilizarov distraction. If you try to do conventional fusion, I think you have very severe soft tissue issues, particularly with virulent infection. And this is the patient's x-rays at 6 weeks after an arthroscopic fusion, and I think that illustrates the power of keeping your soft tissue envelope intact. AVN, as mentioned before, this is a very good indication. It is particularly useful in quadrantic AVN, where there's one or two quadrants which have started to collapse, and you can usually find a rim of hypervascular bone that you can capitalize on. You can use that rim of hypervascular bone around the quadrantic collapse to effect your fusion. But you do need to be somewhat realistic. If you've got severe collapse with deformity, perhaps that's not the right patient to undertake an arthroscopic fusion. These are examples of arthroscopic fusion given to me by Mr. Heppel, a friend from Bristol, where they show excellent incorporation of the fusion site. What about severe deformity? This is a polio patient who had multiple operations to try and correct a very severe equinus deformity. You can combine technologies, and this patient had a frame applied and a slow correction of the equinus, and then eventually had an arthroscopic fusion. Because he had had so many operations, he was very scarred, and it's a good indication to undertake arthroscopic fusion. There are extended applications, which is really outside the scope of this talk, but I just thought I'd put this in. If you did have triple joint disease in addition, you can scope all of them, although I've tended to not scope the calcaneocuboid and the talonavicular joint. You can undertake a pantalar fusion, and the subtalar joint is very easy to arthroscope, and as a routine now I perform most of my subtalar fusions with even with moderate deformity using an arthroscope. It's actually much easier. The vision is far better. You can get well anterior, almost to the anterior facet and the anterior process of the calcaneus. So I think if you do acquire the skills, I think this is a very useful method of safely effecting what in effect is a difficult operation. And this is an example of a tibio-talar calcaneal fusion with successful consolidation of the fusion sites. We do have complications. I have stopped using medial screws because I've had this particular problem. This is actually not my patient, but you can get a stress fracture. If you have two large 8mm screws applied close to each other on the medial surface of the tibia, it does raise stress in this region, and there is a potential for you to get a tibial fracture exactly at the spot where you would hate to get one, because it's a difficult area to heal this. You can get non-unions, but as Trish said, I think non-unions are, in my experience, definitely lesser in arthroscopic fusions compared to the traditional open technique for obvious reasons. You do have a certain risk of neurovascular injury, particularly with your lateral branch of superficial peroneal nerve, but I have had situations where I was made aware that there were patients with posterior tibial nerve injury because of rather exuberant posteromedial release, and there was one patient who was referred to me with a pseudoaneurysm of the anterior tibial artery, an unfortunate consequence of rather enthusiastic excision of synovium from the front of the joint. So in summary, take-home points, I think it is paramount that you have a thorough knowledge of the structures, both around the ankle joint, but also the landmarks within the ankle. It is extremely important that you have the relevant arthroscopy skills in order to be able to undertake an operation. It's very easy to destroy an arthroscope by inadvertently getting your burr to touch the arthroscope, and then it's a hideous operation because your entire ankle joint is full of bits of metal and fiber. So you do require the arthroscopic skills of triangulation and positioning in order to do that. There is a learning curve, and the first few operations take a couple of hours on occasion. It does take a long time, and you start to wonder, well, if I'd done an open fusion, I could have done this in about 45 minutes. But it is well worth going past the learning curve because the biological benefits are significant. It is a safe and effective technique once you get good at it, and you can use it for your extended applications. Thank you very much. Can I ask Mr. Blundell an ultimate talk on total ankle replacement? Is that yours? Yeah, this is mine. You're on this? No, I'm on this. Yeah. I'm just going to take.
So late, everybody, in a lovely sunny afternoon it is out there. I'm going to talk about ankle joint replacements in the round, a little bit of my experience, a little bit about what they are, why we do them. It comes with a health warning. I think I've been a specialist foot and ankle surgeon for the last 12 years as a consultant, and I think this is the hardest operation that I do. It isn't one to be taken lightly, and at the end of listening to my talk and watching a video, you're not trained to do total ankle replacements. It is a steep and long learning curve. It was interesting that when Trish was talking about arthrodesis, one of the first people she mentioned and talked about there was Charnley. Sir John Charnley, of course, was the godfather in our country, at least, of joint replacement with stainless steel and polythene. And with respect to that, we haven't moved very far with respect to ankle replacements. So why would you do an ankle replacement? Well, clearly, it's for a patient with painful ankle arthritis. And as Trish said earlier, that can be post-traumatic or degenerative, i.e. primary, or inflammatory. And I think I pretty much belong to the school that doesn't really believe primary arthritis exists very much, and most of our patients have either got post-traumatic arthritis or inflammatory arthritis. And the goals, of course, are pain relief, because that's really what your patients complain of. And sometimes your patients complain of stiffness within the ankle joint, but by and large this is a procedure aimed at giving them pain relief, but also, of course, maintaining some range of motion. You've got to consider when you're talking about joint replacements around such a small joint with such high loads, the demands that are on that joint, and some of the local anatomy and the local biology is paramount when you're thinking about this. It's absolutely vital to look at the demands and the aspirations of the patient and the surgeon. So why would you not do an ankle replacement? Well, there are some absolute contraindications, and an absolute contraindication is infection, either active or a history of joint infection. So a patient who's had septic arthritis and that they've got a post-septic arthritic ankle should not have an ankle joint replacement. There will be bugs in there, you'll reactivate them, and that patient then has a very high risk of losing their limb. Avascular necrosis, by which I don't mean little tiny areas of avascular necrosis, I mean a talus which is substantially or in a large part dead. Relative contraindications is quite a long list, and I guess is somewhat dependent on where you're coming from. But for me, deformity is a relative contraindication. It used to be said that for every ankle replacement you did, you could do one more degree of deformity. In other words, your first ankle replacement should have 0 degrees of deformity, your second can have 1 degree, and your 10th can have 10 degrees. But the literature now really supports that people should not do ankle replacements unless they truly are an expert in ankle replacement in anything more than 10 degrees of deformity. Stiffness is a contraindication because an ankle replacement won't regain motion that hasn't been there for many years. So if you've got a patient who's only got really a jog of motion because they've had an ankle injury, an ankle replacement is not going to give them a normal range of ankle joint motion. And you might have nice shiny looking x-rays, but if the ankle's still slightly sore and it's still stiff, I would countenance that patient would have been better off with an ankle arthrodesis. I don't think you should do an ankle replacement in a patient who's got diabetes, principally because a high proportion of patients with diabetes will get neuropathy. And we know that those patients with neuropathy are at high risk of getting fractures. We know how hard they are to manage. And a fracture around, or a Charcot disorder around an ankle replacement is an unmitigated disaster. So I don't think if you've got a patient with diabetes, you should do an ankle replacement. Bizarrely, patients with psoriatic arthropathy, and I don't know if that's a condition that is witnessed in India, but patients with psoriatic arthropathy do badly with ankle replacements. And I don't think anyone knows why that is, but they do. It's absolutely essential that that patient's expectations are very, very carefully countenanced when you're deciding whether to do an ankle replacement, and that they do understand that this ankle replacement will get rid of some or most of their ankle pain and will give them some but not normal movement, and that there are risks behind it which are very significant. And your expectations as a surgeon offering that patient the ankle replacement needs to be that this is a lifetime relationship you're going to have with this patient, because there aren't enough ankle replacements done for you to be able to ever discharge this patient. And I think if you're doing an ankle replacement, it's your responsibility to look after that patient for the rest of your days or their days. So the complications of ankle replacements, of course, are the complications of all surgical procedures, and early on there's a high risk of infection, or a higher risk of infection, and the literature suggests it's somewhere between 2 and 35%. The better you are, the less the risk of infection, but none of us has a risk of infection of nil. And there are wound healing problems, and the anterior approach to the ankle is a tricky one. And you have to be very, very careful, because right underneath your skin is the extensor retinaculum, right under that is the tendons. And if that retinaculum fails, those tendons will saw their way through the wound. You'll be looking at tendons, and that ankle replacement is then probably doomed. Intraoperative fractures are relatively common, and although you don't want them to happen, if you recognise them and you fix them, that doesn't seem to have a long-term detrimental effect on the ankle replacement if it's an intraoperative fracture. A fracture that occurs later on does, because a fracture occurring later on probably signifies that that ankle replacement is failing, because there's progressive malalignment, progressive abnormal bone loading, and then a fracture. So late complications are the same late complications that can occur with any arthroplasty, so loosening, cysts and lysis, bearing fractures, because these are mobile bearing replacements for the most part, and wear. And of course there's implant failure down the track. And these have all got to be discussed with the patient before you think on embarking on an ankle replacement. So how many are done around in the world? Certainly the largest national joint registry in the world is the UK National Joint Registry, and those are the figures from last year. So there's 85,000 total hips, 95,000 total knees, and 700 total ankles. We are orders of magnitude less than our hip and knee cousins, and that's because ankle arthritis is a less common condition, because we've got an alternative procedure which, as Harry and Trish have very eruditely said, is the gold standard. So people are cautious about doing ankle replacements, and rightly so. I am an enthusiast. I may not sound like I am, because I want to give you a strong health warning. Mobility ankle replacements, which I think is an ankle replacement that's being proffered towards the Asian market, is interesting, because when that came about in 2004 in the UK, it was a huge uptake because the instrumentation was very nice. And in 2011, they had 80% of the market in ankle replacements in the UK. Last year, that had fallen to just 65%, a pretty dramatic fall. And the two reasons for that I can see are because other ankle replacements have come on the market which argue that they are just as good, that the results of mobilities have yet to really be published in any meaningful way. We've published, or in publishing, but that there aren't many studies, despite the fact that thousands of mobility ankle replacements have been put in. And because I think there are some problems with the mobility ankle replacement, which I might get a chance to show you a little bit about. Who should do them? In some parts of the world, there's a debate as to whether they should be done by foot and ankle surgeons or arthroplasty surgeons, and that debate existed in the UK about 15 years ago, and it still exists in America. We now in the UK think that if you're doing ankle replacements, it's the remit of a foot and ankle specialist, because this is a very hard operation, and the anatomy and biomechanics in that area need to be really well understood by you. It's